All right, now, does this technology can it give you, does it matter clinically in its application? Dr. Walcott published a paper with 1,300 wounds in the Journal of Wound Care, 3 groups. The first group got cultures, second group got cultures with systemic antibiotics, the second group got molecular with still using oral antibiotics, the third group got molecular with customized topicals. Each group, chronic wound, all got the typical wound care that you would do, weekly debridements, offloading, vascular workups, everything you would do for a chronic wound. The difference is this group just using cultures, the healing rates were 48.5%. This is very typical in chronic wound studies. If you look at Apligraf and Dermagraf as 2 products that went to the FDA, their healing rates were 45 and 38%. The comparator is wet to dry, which is always like 22%. So the FDA says, well, you beat wet to dry, so we'll give you FDA approval and reimbursement. But they still don't do that well. But this number is not unusual. So just changing to molecular now from cultures as my diagnostic tool, but I'm still going to prescribe systemic antibiotics, my healing rates went up. Well, it's logical if my diagnostic tool is more accurate, I'm going to pick the right antibiotic. So if I get dominant anaerobes, I put the patient on Augmentin versus Keflex, then I should get a better response, and that's what he found. The third group, he used molecular, but then took those same antibiotics, instead of putting them and delivering them systemically or orally, now put them into a base and applied them directly onto the tissue. And a lot of people push back on, and I'm not here to promote topical antibiotics, but I'm going to tell you, when you're dealing with chronic wounds and in nails, they work a lot better. And it makes sense because people that get wounds, they have poor vascular anyway. How are the systemic antibiotics getting to the site, to the vascular? They can't achieve high enough concentrations. Think back to my bleach model with the BioFilms. They can't get in. Now if you take those same antibiotics and dump them directly on top of the tissue, you're delivering 1,000 to 5,000 times the concentrations, which is why you get much higher healing rates. Days to heal, venous leg ulcer, most common, went from 177 days in the first group down to 98 days, just changing the diagnostics down to 37 days using molecular combined with topical. This is that lady I showed you in the beginning who was scheduled to have a BK the next day. This is her 12 weeks later. If you had taken one of your expensive graft products, whether you're using the amniotic or whether you're using Apligraf or Dermagraf, and thrown it into this wound, just like they eat the tissue, they will destroy your graft. So by using DNA-guided customized topical antibiotics and then doing your grafting, you get much better outcomes. Now sampling is the next question I get. How do I take a sample for this technology? The best sample is tissue. So what we like you to do is, if you say to me, oh, the slough is going to have a lot of bacteria, I don't really care about that. Then take some 4x4 with some saline and wipe the slough off of the wound bed, and then take your 15 blade of your curette and scrape the entire wound bed. If you just go in there and just go in and take a piece of tissue over here, I'm going to tell you who I found living there. Microbes are diverse across the wound bed. They're like part of Chicago. If I go in the North Chicago, I'm going to find out who lives there. If I go in South Chicago, I'll find out who lives there. If I go in the middle. So you get the idea. I need the largest surface area as possible to give you the best diagnostic results. If you're an aggressive debrider and you debride, because you know debridement is the cornerstone, we know that, but when you do aggressive debridement, if you cut really deep and then you give me a small tissue sample from where you went really deep, I'm just going to get a lot of host DNA and you're going to get an inconclusive result. Inconclusive means we didn't find enough DNA in your sample. We didn't have enough reads to meet our threshold to determine the type of species that you're dealing with. There are also things that will inhibit our test. Lidocaine is the biggest culprit. Lidocaine is highly acidic. The pH is what causes the degradation of the DNA. So if you put lidocaine gel on your wound, and then you take a sample, and it gets on the tissue sample that goes in our little FedEx box, it will degrade the DNA, and you will get an inconclusive. I don't want that to happen to you, because you're going to be like, well, that's no better than getting a no-growth culture report back. So if you use lidocaine, in some places on the ankle and the leg, you have to. If you inject it, it's not a problem. It's when you use the topical that gets on the sample where it's a problem. If you wipe it off well with some saline, we should be okay. Tetracaine we've tested doesn't have the same effect, but very few podiatrists use tetracaine. The ENT guys all spray Afrin, lidocaine, tetracaine before they do scopes, so we had an issue with their samples also. Nails, the same thing. On nails, if you put your clippers in a wet sterile, that's a biocide. If that biocide gets on the nail sample, it will degrade the DNA in there, and we will not find enough reads. So if you can avoid using your clippers with the biocide on them, or rinse them with saline or autoclave, is your best bet. And also, if you can just scrape and get some debridement material in there too, even better. I'm not going to go through that. Now, if you say I'm not going to switch to this, I'm really not convinced, I'm going to continue to use my micro lab. You should be aware there's national guidelines for microbiology. These were published in CID, and I'm sure you all read CID. Even the IDs I show this to haven't read CID. So, but the two groups that make these decisions, the IDSA, the Infectious Disease Society of America, and the ASM, the American Society of Microbiology, they come together and they say, hey, we're tired of being blamed for no growth culture reports. It's not our fault, because we have to have a good sample, good specimen for us to do our job, which is to grow bacteria. So this is a 100-page document to all clinicians about your requirement to get on specimen management. And the two criteria that they hold you to are time and temperature. Don't give us a good sample in the right time and the right temperature. Don't expect us to grow any bacteria and give you a report back. So there's full of tables that have all these tables, and they say RT, room temperature, 2 hours, 2 hours, 2 hours, room temperature. And the impact on specimen management, on patient care is enormous. And that specimen selection and collection are the responsibility of the medical staff and not the laboratory. That's the lawyer saying it's not the lab's fault, it's your responsibility to get us a good specimen. But the reality is this is what we have in healthcare today, in these boxes sitting outside of offices. And I live in Orlando, Florida, so today it's 80 degrees and it's probably it'll be well into the 90s shortly, and these samples sit out there and they bake. And the insurance companies who I meet with say, they've done a great job on pitting Quest and LabCorp in a bidding war. So they drive the price down, they get their microculture for even less and less. But then I say to them, well, but those guys, they have to save money. So what do the labs do? They consolidate their labs. So they'll close labs down, and now they'll put your samples on airplanes, and they'll fly them to other states, and they'll fly them to other cities, and pick them up and drive them places. Are they making it there in 2 hours and being kept at room temperature? They don't care. They're getting their $80. And if you get a sample report that says anything on it or it says staph epi, then so be it, they did their job. But it's not going to be even close to what's actually you're dealing with in terms of that wound or that nail. Non-viable DNA, if you go back to your infectious disease friends, they'll say to you, well, this technology is really interesting, it's might not be ready yet, but they can't distinguish between bacteria that comes from viable bacteria or non-viable bacteria. So the ENT guys have looked at this, and basically, in short, the non-viable bacteria DNA is really gone in 24 hours. So the body, the host, and the community is really good at cleaning up. So yes, in your samples, will we find DNA from non-viable? It'll happen, but the percentages are going to be very small. Because again, in 24 hours, the studies show the non-viable DNA is literally gone. All right, this is my last slide. So again, cultures still have their place with acute infections. In the hospital situation, you're never going to use this technology if you have streaking up the leg and you have all the signs for a cellulitis. You're going to treat empirically. You're not even going to wait for probably a gram stain or anything else. But if you're dealing with chronic infections, nail infections, bone, hardware, then this tool is much more accurate. It wasn't available because of cost. Medicare reimburses it $191. If you live in the state of Illinois, we have Blue Cross and Blue Shield contracts. They pay for it. In other states, you can check with me afterwards, and I'll tell you what the commercial insurance situation is in your state. It is the gold standard. It's the gold standard for the criminal justice system. It's the gold standard to determine who the father of the baby is. And it's the gold standard to determine what microbes you're dealing with. And it really is less expensive than culture. At $190, the maximum we'll charge patients is $199. If you go into Quest or LabCorp, they'll give you a basic CNS for that price, but it won't include anaerobes or fungus. And with ours, you're getting everything. If there's fungus DNA in the sample, we will tell you. If there's anaerobe DNA, we will tell you.